Alice, you and others are involved in the development of other compounds in the same therapeutic venue. Can you talk a little bit about the Merck agent?
Yeah, so this is MK-3475, or lambrolizumab, which actually certainly has had really amazing data in melanoma. And now we've seen or heard about some data from Eddie Guerin at World Lung, and there's an update as well, I believe, at this ASCO. Yeah. But I think the data with MK-3475 has looked quite comparable to what we've seen with nivolumab. Response rate was in the 20–25% range for non-squamous and squamous patients. And the safety has also looked similar. I don't think there's been any pneumonitis noted with MK-3475 the way it has.
It's been a relatively innocuous drug, at least in my
really
experience.
Well tolerated.
And there are plans, actually a phase 3 trial has been initiated.
Of Lambro versus docetaxel.
With 2 different doses of the Merck compound.
That's right.
The thing that's interesting, Corey, about the phase 3 is it's 1 trial, not 2, for all tumor types, and it does have a biomarker component. So there's a certain biomarker component to get into the trial, and then it's stratified for a high or a low level of biomarker. So this is now embedded in this trial. Having come second, I think there's been more analysis of the biomarker, so perhaps that might make a difference in this study, but also versus docetaxel.
And they too are looking at frontline and the PD-L1 positive. And Ross, you and others have been involved in the development of the Genentech compound, which is more specific for PD-L1.
Yeah, so it's MPDL is an anti-PD-L1. But it's a very similar sort of story. You know, you're getting a sort of 20-odd% response rate in an unselected population when you use PD-L1, and Roy has a very good point that not everybody's way of looking at PD-L1 is the same, but you can clearly enrich for responders, but you don't completely remove people who benefit by making them PD-L1 negative. I wonder, to pick up on Govindan's point, whether you can still use that imperfect biomarker to prioritize when you might use these. If they're positive, you might want to use them in the first line. If they're negative, because there's not an absence of benefit, maybe you're pushing it further down the line of therapy.
And the activity with this compound has also been seen in smokers and individuals with KRAS mutation, folks who are not really candidates for standard targeted therapy. Yeah. So there's a confusing array of phase 2 and phase 3 trials. Roy, where ultimately do you think this is heading?
Well, I think the good news is that we're seeing activity. The response rate across the board is around 20%, a little north or south of that for all these agents in the unselected population. There's also a drug from MedImmune, with similar activity that's presented here at ASCO. What's next? I think they're all different. Every antibody is different affinities, different targets. Some target PD-1, some PD-L1. What's the difference? The thought is if you target the PD-L1, you leave PD-L2 intact, and many think that PD-L2 is important in harnessing the normal immune system so that the PD-L1 agents might be a little bit less toxic. I can tell you, having worked with all of them, I can't say that based on my experience. I think after we see data from phase 3 trials, maybe that will help.
As someone who's worked with just one of the compounds, it's my impression that the results we've seen in terms of response rate, to some extent, to a lesser extent toxicity, are all very similar.
I agree, Corey, and I think it's going to be the biomarker, and whether it's some aspect of PD-L1, what cutoff, there's no perfect cutoff, when you look at these ROC curves and you try to pick a cutoff, and where do you measure, I think that might help. I think what we're investing in at Yale now, given that we have our melanoma group, Mario Snow and others who have come before, our scientists, Li-Ping Shin and others, is an immune monitoring core. We're looking at ways now where we can study these patients with biopsies pre and post and try to understand in those who do respond, who might not have the PD-L1 positive, what else is in play, or for those more likely who are resistant, what's going on there? Because I do think the next step now is not the 20% who are responding, maybe the 40 or 50% you could bring it up to with a marker, but what about those other 50% and how can we do combinations?
So really, at least as of now, we have no easy way of choosing between these agents if and when they get approved. The first approved will be the first used.
Right, I think it'll be harder for those later on if one becomes approved. I can tell you that, it's funny, I look at my program, now here at Yale versus a lung program I ran 5 years ago, and it's moved, except for the never smokers or the light smokers with some of the molecules that are discussed in this program, it really has moved to an immunotherapy program. We have 4 or 5 different immunotherapy trials. The hardest part is they all have different criteria for entry. The same tissue section can be eligible for one trial and not the other. I know Alice
Which
and I
underscores the tremendous heterogeneity that exists in assessing PD-L1.
absolutely, and Alice and I share many patients back and forth. Sometimes they're eligible for a trial at Yale, and if not at Mass General.
Well, fortunately, they're only 2.5 hours apart.
Yeah, but the bottom line is, Corey, there's activity, and it's actually the perfect setting for us because we know we have something with activity. When you see these responses, they're durable. The patients have side effects. It's not a free ride, but it's better than chemotherapy, in my opinion, and it has memory. It can last for a long time. So there's already enough there to make these drugs, in my opinion, and now we can make it better.
Responses will often continue even after the drug's been stopped at 6 months or a year.
Exactly. I think my opinion is it's probably better to keep on treating, but many of these trials did require stoppage at either 1 year or 2 years, and most patients did just fine after that.
There's been the